You're live.
Happy Nurses Week. Welcome. I'm Dean Sarah Zanton of the Johns Hopkins School of Nursing, and I'm the moderator for Facebook Live Nurses Everywhere. The COVID-19 pandemic is a remarkable and challenging time to be a nurse. And we hold a unique position because the world recognizes now that social determinants of health and understanding a person in the context of their life circumstances is nursing's wheelhouse. Already 4 in 10 nurses do not work in hospital settings, but the world is slowly waking up to that. At the precipice of change, with a unique perspective on where healthcare is headed, we've brought together experts from Johns Hopkins, along with doctoral alumni, to talk about nurses in the community and how we are shaping the future of healthcare. So we'll start with introductions. Dr. Ling, would you introduce yourself?
Hi, my name's Catherine Ling. I am a family nurse practitioner and I am an associate professor in the School of Nursing. I have been a family nurse practitioner for the last 30 years and have worked coast to coast and am delighted to have this discussion about nurses and where we're going.
Great. Welcome to the panel. Dr. Kim.
Hi, my name is Marini Kim. I am a pediatric nurse practitioner and a graduate of the Executive DNP program at Hopkins. I'm currently working as the Director of Nursing at Pocket RN and also teaching part-time in the Hopkins programs as well. So yes, just like Dr. Ling said, really excited for this conversation.
Great. And Dr. Phillips.
Hi, I'm Katie Phillips. I'm a family nurse practitioner, and I'm currently the medical director at the Esperanza Center Health Clinic, which is here in Baltimore City. And happy Nurses Week to everybody.
Dr. Maria.
Hi, my name is Christina Maria, and I am a PhD graduate of the Johns Hopkins School of Nursing. I am an assistant professor at the Georgetown University School of Nursing and Health Studies. I practice per diem clinically at Community of Hope and FQHC with the only freestanding birth center in Washington, D.C. And I also have the honor of serving as the co-chair of the D.C. Maternal Mortality Review Commission. Happy Nurses Week.
Welcome. And Dr. Pollack.
Everyone, it's such a pleasure to be here. My name is Craig Pollack. I'm a primary care physician. I work clinically at the Johns Hopkins Outpatient Center, and my research focuses on the connection between housing and health, how we can use housing to support the health of broad range of populations.
Great. Well, you can see we've got a wonderful panel, and we're going to switch to first names now that we've been super official. And so first question to you, Christina, what do you see as driving the healthcare shift from clinical inpatient to more community focus?
Well, I think so many of the health concerns of our patients across the lifespan are directly related to their lived experience, their behaviors, their environmental exposures, and the structural factors in society that are impacting their health. So when we think about the clinical care that our patients and our communities need, by the time they get to the hospital, they get to the clinic, those health disorders have already taken root. And so by moving into the community, we can meet people where they are, we can understand their lived experiences and connect with them. And for many of our patients, particularly those that have been structurally marginalized, experienced racism, or other forms of exclusion, the healthcare system sometimes hasn't been a very trustworthy place. And so rather than asking our clients to come in somewhere that maybe hasn't treated them or their community well historically, it becomes our responsibility, our burden, our privilege to meet them where they are, to address the health needs that will help them thrive, that will help them live in their families and communities.
Great answer. Craig, did you want to add into that?
I absolutely love what Christina said, and I think that's absolutely right. So this is yes, and I also think that the healthcare system is starting to wake up, that more care needs to be done in the community. We've seen with COVID, so many of the social risk factors just laid bare with people's housing precarity, just so strongly indicated that people are losing their homes, they're not able to catch up on their bills. Sorry, there's some noise in the background. And then I would also say that with that, we have some changing in the payment structure of healthcare that's making some of these types of approaches more feasible. And so I'm thinking about some large payment things like moving towards more bundled payments for some types of surgery, moving towards accountable care organizations, where there's a sense that like we've been focused so solely on this fee for service where you're paying for what each and every individual service and maybe missing the bigger picture, bigger context of where people live and how they live, and that some of these moves allow for greater coordination and greater moving into the community.
Great, wonderful. Here's one to you, Marini. What new technology and infrastructure is available that it's creating space for care outside of the clinical setting?
Sure. So, just speaking from my experience where I work at Pocket RN, it's a telenursing platform. And so it allows patients to have on demand video access to a nurse at any time. And so we've learned a lot from this. Our platform specifically actually does specialty matching as well, which can be a huge value for patients. You know, for example, if they have a chronic wound issue, sometimes a normal phone call triage center can't really give you the answers after hours. And so being able to connect with a nurse who has that expertise when you're at home is really helpful. And so I think this is key. I love what Christina said about meeting patients where they're at, because that's something that we've learned has been hugely valuable. And so, yeah, I think creating that space where you can see patients in their home environment has also really added a totally new dimension to the care. We hear from the nurses a lot of things that I don't know you'll always pick up on in a clinic visit when the patient is coming out of their life and entering the clinic in your space, versus you getting to see them at home with their relatives who are also an integral part of their care as well. So yeah, that's my experience and learning a lot on that front as well.
That's a great point. I think also things like telehealth are also helpful for keeping nurses in the workforce longer. That I believe in your company, but also in other telehealth situations, take advantage of the very wise nurses who've been in practice for years and years who might not want to work 8-hour days somewhere else, but can work from the comfort of their home. Catherine, to you, would you like to also answer what new technology and infrastructure is creating space for care outside the clinical setting?
Absolutely. I thought Marini did a fabulous job, especially with that example of having that on demand. And that's really what technology and infrastructure are creating, is that space where people can have in their hand, in their pocket, that type of care where they can get it not in 3 days, in a 10 or 15-minute time slot, but they can really begin to go forward. Apps have just absolutely are burgeoning out there that help people do self-management, and that interface between the clinic visit and information that they can have in the app and or any of the devices that can be put on a phone now. The fact that we can do really pretty much a hands-on exam virtually is a fantastic issue. The flip side of that, though, is what are the assumptions of the infrastructure, and where are we not able to meet people where they are? Apps are great, but if you have any kind of visual concern or you have any kind of fine motor issue, they may not be as user-friendly. So I think that as we begin to burgeon forward, as we have a generation after generation of digital natives who expect to be able to conduct a lot more of their business virtually, we can't forget about those folks, as well as folks in spaces where the infrastructure may not be as supportive. Not every place has Wi-Fi access. Not every place has cellular access. Not everyone has a smartphone or desires to be reached virtually. There's still some really good cases for analog. So I would say as we build up the tech, we need to also make sure that we're building up with high tech, high touch infrastructure to where we can make sure that those critical spaces and people are not missed.
Those are great points. I think also in terms of the infrastructure, you know, think of how much people are more often likely to live near a CVS or a Walgreens or something similar than to, you know, a doctor's or nurse practitioner's office. And so there's also, for the people who want to be seen in person, there's also kind of the infrastructure of you know, primary care being all different kinds of places as well. And of course, school health. And so, but Catherine, just to go back to what you said about what can be done virtually that's a clinical exam. I think for our audience, if people haven't thought about that, they may think, well, I could look at you, but what else can be done in an app, or maybe it can test my.
Oh, sure.
Right. So can you, just for the audience, for people who may not have thought of this, can you just say a few of the things that you think might be interesting to people that can be done in terms of a physical exam when they're not in the same room?
Absolutely. So I'm wearing wearable tech right now in the form of my Apple Watch. I can get my pulse oximetry, which tells how much what the oxygen level in my blood is. I can check my blood pressure and keep that monitored. I can check my heart rate. There are now things that can be put on your camera that if you are if you have my favorite one is where you can do an ear exam, where you can do otoscopic exams just with the camera, where folks could hold the camera up to their ear with some of these assistive devices. You've now also seen some of the folks with the wearable tech on their arms, where you can get your blood sugar. You can pass your phone over that and you can have consistent monitoring. So those are all pieces of things that make it easier to see people in real time in the real space.
Thank you. Did anyone else want to jump in on that, or we'll move on to the next question? Yeah, Craig.
I also want to say, I think, it's interesting the way that COVID has really supercharged this with so many of the patients that we see. We've been kind of forced to start doing telemedicine very, very quickly. And so I think there's so many lessons that we've learned. And I think there's a lot of potential for some of the high tech kind of approaches, but even the much lower tech approaches of being able to see someone in their house and have them show their medicine bottle, show their shoulder range of motion, that you're able to learn so much from what we have right now for so many individuals. And it's really been transformative. And I think it'll be interesting and important to see kind of how this plays out over the coming years. And I suspect we'll only continue to see it grow, while at the same time learning some of the limits of this approach and the strong desire to actually have a face-to-face conversation with people that isn't mediated by a screen.
And I think also we're learning that for a lot of the big organizations that charge partly a facility fee and partly a clinician fee, and that was all kind of waived during the height of COVID. But now I think some places are really asking patients to come back because they need that other part of their fee to break even and stay alive. But families and children are like, why do I have to drive 2 hours to get to your thing just to support you? So I think that'll be really interesting to work out in terms of this transition. Katie, how is the transition to care outside of the traditional clinical settings helping underserved communities?
Yeah, so I work with the undocumented immigrant community, and like Christina mentioned earlier, my population has a lot of mistrust for kind of large institutions, large hospital-based institutions, government institutions, and so it's been really, really important for us to create a welcoming space in the community where they live, where we speak their language and they're able to come to us and seek care. But one thing I think that has really, just kind of touching on others' points about technology, I was laughing when you mentioned, Craig, just a couple of weeks ago, I evaluated, a lot of my patients are day laborers. And so if they have an appointment to see me and they get a job that day, they cancel. And last week I evaluated somebody's rash in the parking lot of the Home Depot where they were getting a job. And so being able to see that patient where they are is really one of the benefits of telemedicine. But I was going to comment about, our community was particularly impacted by COVID at the very beginning of the pandemic because of their crowded housing conditions, because they were essential workers and were not able to stay home during that initial time in March and April of 2020 when everybody was at home. And so we really kind of started to panic and hospital beds, and we were following the census at Hopkins, and it was all Latino immigrants. And so, but one thing that emerged over the next couple of months was that many of those folks who were hospitalized with COVID from the immigrant community it was their very first interaction with the healthcare system ever in the US. And so all of these things were coming out. They had really out of control diabetes. And we sort of thought, wow, like we have this community-based clinic at Esperanza Center in the community, and all these people still aren't even making it to us. And the only reason we discovered their chronic diseases were because they got COVID and they had to go and into the hospital. And so we decided to really expand our community health worker workforce and send those folks out into the community. And so now we have community health workers out on the streets every single day. They go to the Home Depot parking lot, they go to Latino grocers, they go to churches, they go to schools, they do rapid hemoglobin A1Cs, they do COVID testing. So really going out and finding people where they are and then getting them linked to care. And it can't stop there, right? We have to kind of follow them. So our current initiatives with our community health workers follows those patients that we identify out in the community for 6 months. They get home visits, they get linkage to care, and then we track obviously their health outcomes as well. And so I think for us, it was really eye-opening because we feel like, oh, we're seeing the immigrant community in Baltimore right here at a community-based clinic, but there are a lot of people who aren't even making it there. So the community health worker model has been really great for us in getting out into the community and meeting people where they are.
That's a really interesting story. And the fact that someone would need to be hospitalized to find it when you're doing so much work already. Yeah, thank you for that. And Christina, did you want to weigh in on how the transition to care outside of a clinical setting helps underserved communities?
Yeah, absolutely. And similar, listening to Katie's description, it made me think of, this idea of like concentric circles that are really expanding with like the tertiary care hospitals, where people are having to travel the farthest to come in, and then the community health centers. And Washington, D.C. is a really interesting example in terms of bringing care into the community. In 2017, we had 2 hospitals on the eastern half of the city, that's the predominantly Black portion of the city, closed down. So we have this massive care desert for an entire population where 85% of the population is Black. And so just getting clinical care into those environments is incredibly important, because the transportation barriers of getting from the east side of DC to the west side of DC for clinical care is really insurmountable, especially if you don't have a job that gives you vacation or PTO, if you are paid hourly, if you don't have personal transportation and are relying on public transportation in neighborhoods where buses are unreliable, and you need childcare, but you don't have access to it or can't pay for it, or children aren't allowed in visits, which even predated COVID and has even become more extreme. So then we think, okay, we need to get clinics into these communities where there's been this shutdown, and it's very much along like racially and socioeconomically segregated lines in our city. Well, okay, so then we add some clinics, but are those trustworthy? Are people still able to get to the visits? And so we move into the telehealth environment. And then going back to that discussion about technology and infrastructure, like some of our clients are technologically accessible, and some of them, are paying data plans where they don't have the bandwidth for that. And some of them, their phone numbers are changing frequently because of this structural and like economic marginalization. And so then having at Community of Hope specifically, we have this incredible team of MCH and perinatal care coordinators that are connecting with clients by phone, by text in the community, and really focusing on that intersection between what are the healthcare needs and what are the social needs, right? If you can't get food, you don't have stable housing, getting to a clinic visit to manage something else that's, blood pressure that's not acutely urgent right now, but is going to become a long-term problem, is just incredibly complex. And these are prioritizations that our patients are having to make in terms of their health and their ability to survive. So having healthcare available in as many different modalities and locations and frequencies, and particularly by people who are invested and connected and trusted by the community, are so critically important.
Great. And I'm reminded of thinking about school health. I think Catherine and others have been thinking a lot about how do we reach people through the schools and the churches and other places people already go. And Catherine, I wondered if you might weigh in on that.
Absolutely. So when you're talking about defining care deserts. And I thought that was a really salient point that Christina, that both you and Katie made. Think about where people do spend their time. They do spend their time making sure the children get to school. When you look at the fall off of immunization rates that happened during the pandemic, where were people still showing up? Where were they still going? And it was schools, and it was faith-based organizations, and it was out for essential services like gas, like food. And so when you think about where care really begins to meet at that intersection, care and life, it's not in a 15-minute visit you waited 2 hours and took 4 buses to get to. It is where they are. And people have been creating a call for on-demand care for as long as I've been in healthcare. I started off as a family nurse practitioner in Atlanta, and we were dealing with, in the early 90s, really skyrocketing rates of ER use. That is a signal for on-demand care. It is not necessarily a health literacy signal. It's I can really only see somebody between 6 and 9 p.m. I don't have the other pieces. So I think in some ways we need to flip from a healthcare side, flip our perception on what our parameters are, and really listen to our communities and be present in them. I think some of the most innovative pieces are clinics for whole families that are set up in school districts, where you have a stable nursing presence, not in a school system or district, but in a school. That are reaching out there, and they know the family from the kindergartner to the grandparent. Also in fire stations, volunteer fire stations. You talk about rural critical access areas where a lot of healthcare services have disappeared. Almost all of them still have a volunteer fire department. And so thinking about some of those enduring spaces where people do come, that they do have some of those elements of trust, I think that those are where we need to begin to build that 21st century practice.
Those are great points.
Yeah, I just wanted to jump in there, if it's okay.
Yeah.
Yeah, so Catherine, as you're speaking, I think I just echo all those points. I think one thing that we lose sight of is that the various populations, like they don't, the typical healthcare schedule is not always conducive for the life that they live. And so sometimes as providers or practitioners, it's really easy to kind of see someone or a group or whatever as non-compliant. But if you actually open up those layers and understand why they're not able to make those visits, it makes a big difference, right? And so that's one thing that I've seen a lot, where, you know, you hear someone say, well, I'll give you a doctor's note. They're like, well, actually the work I do, it's simply giving me a doctor's note for missing work again for my child who has this new chronic illness is not sufficient. And they need to make sure that they can keep this job, right? And so that's definitely a challenge. I think that's one of those exciting things about virtual care, is having that on-demand access even in the evenings, right? There's a convenience factor for the nurses working on the platform because they can be at home in between the calls. And then there's a convenience factor for families and patients to be able to do this when they're not working. You know, we've definitely seen Friday evenings is a very popular time for people to call in. It's like when they finally have the bandwidth and the time to figure out what's happening with their health, when they have all these other priorities in their life, suddenly there's issues that come up. And we've definitely had patients express, you know, if I didn't have this conversation with this nurse at Friday evening and they were able to coach me through this procedure I need to do on myself at home, I would have had to go to the emergency room because I have no other options at Friday night. So that's something that we definitely learn are some of the benefits and advantages of having on-demand virtual care.
And it kind of reminds me of how, you know, people say, and of course this happened at Friday at 4, right when everything was going to shut down. And really that should be a signal, like we should have more services late Friday afternoon rather than, you know, people should think of things earlier in the week.
Well, I wanted to jump in one more time and just, you know, thinking about moving into the communities to highlight some of the moves that have accelerated during the COVID-19 pandemic of community-based birth. And particularly in light of our maternal mortality crisis, right? CDC is preparing to release new data showing even higher increases in maternal mortality. And we're failing birthing people in the outpatient and in the hospital setting. And there's a big desire amongst some communities for more community-based birth. Now, the screening and triaging of who are safe clients, who can safely deliver in the community setting, who can safely give birth in their home or at a birth center, are important conversations to have. But thinking about how do we build out the infrastructure so that people are at the correct facility for their level of risk and the location in which they are going to feel the most comfortable, the most cared for, the most trusted and safe. And often hospitals aren't that for some subset of people. On the flip side, making sure that we have tertiary care hospitals available for people who are very high risk, people in rural communities, people in healthcare deserts within urban settings. But I think movement around birth location is something that's going to continue to change in the coming years.
That's a great point.
Yeah, I just, Christina, that brings up a really critical piece, is that we've been asking, well, why would you have a community birth? And I think it goes to that beyond risk management, why would you not have a community-based birth? It's a life event. And you know, there are risk factors that mean you need higher levels of care, and let's please take care of our mamas and keep them safe and healthy. But you know, we have pathologized to a point some things that are life events that 50, 60 years ago, even before I started practice, were in the communities and were life events, and did have that support of the community members. So I think that was a really important point that you made.
Yeah, and it's similar to this discussion about the ER, right? Which is that our patients need to be at the highest level of care that they currently require. But once they're at a level of care beyond what they require, we're looking at excess healthcare costs, excess workforce costs. And so utilizing nurses and nurse practitioners and nurse midwives and community-based settings to their maximum capacity is saving our clients time, it's saving our health system money, it's the best utilization of our resources, and it's giving people the care that they want and desire in the environment they want it.
Great. So for this next question, I'm thinking particularly of people who are in nursing school now or graduating soon. You know, I think a lot of people hear, well, you should start in a hospital, and no matter what, you should start working in a hospital. And I never once worked in a hospital. I have complete respect for everyone who does, and so glad they work there. But currently 4 in 10 nurses do not work in hospitals. If you look across the 4 million nurses. Where else can we find nurses? And sometimes we hear from nursing students, what is a good path if they're thinking about community-based nursing? So 2 questions, like what are some of the unusual places where you find nurses? I know some of them have been highlighted, but maybe shout them out again. And also, what are some good paths? And I'll just say my first job was working with migrant farm workers, and on my first day of that job, so it was my first day of being a nurse, I needed to track down someone who was on a long-acting contraceptive and give her an injection, and I had to find her, and we met in a Head Start bathroom, and it was very unprofessional. There was no place else to do it, and no sharps container, and gave her the injection, and I was terrified. But it all worked out, and it was a great experience for several months with migrant farm workers. But so again, the question is advice to new nurses about places to work if they want to be in the community, and what are some of the interesting places that you've, including the Home Depot parking lot, but others. Anybody?
Well, we've mentioned schools, school nursing, and when I talk about school nursing, I'm not just, I'm talking about all levels and all stratas of nurses. We all come in different flavors. And one of the things that I tell students that I interact with frequently, there are 4 million nurses, so there are 4 million ways to be a nurse. And the biggest piece that we bring to the professional healthcare team is our ability to assess and have that humanistic perspective, and then apply biomedical science to that and bring in additional team members as we go forward. That does not require an entire building or institution to do. We have a long, varied history with public health nursing. So any space. I've had positions in mills. I've had positions in a federal building. I've seen patients not only in retail settings, but also with a backpack in parks. Anywhere there is a bipedal carbon-based life form is a place where a nurse can take care of them.
Who else? Anyone want to chime in on that?
Oh, I think, nursing is one of the largest, if not the largest, workforces in the world, right? So we work everywhere. And thinking about, what are some of the different pathways as you come into nursing? And one of the questions that I ask my students is, what did you love before you became a nurse? And that's something that's really important to who you will be as a nurse, whether it was an educator. I have one colleague who was a bartender, and she is wonderful at de-escalating intense environments, right? She can support a family through a crisis like no one I have ever seen. But whatever it is that you loved, right? Whether it was literature, it was the arts, it's global health, which is one of my passions. There's a place for nursing work. So in my career as a nurse and a nurse midwife, and I've worked in a hospital as a nurse midwife, but never as an RN. I've worked globally with Doctors Without Borders. I was a volunteer in a refugee camp in South Sudan. And there's a large number of clinical nursing opportunities in humanitarian health. I've worked as a consultant with large international organizations like the World Health Organization and UNICEF, conducting trainings, supporting curriculum design. I currently serve as the chair of the DC Maternal Mortality Review Commission. And I think that there is some incredible opportunities on different mortality reviews, morbidity reviews, local government agencies for the nursing voice to be involved. That perspective of humanistic care, life course, social determinants is critical that people are listening to as they're making decisions. I've served as a policy advocate, being on Capitol Hill, giving testimony about ongoing legislation and having direct testimony about the health impacts of the policies that are being discussed in government is a critical role for nursing, and even more so right now as we're seeing changes in legislation that affect people's rights and access to healthcare and self-determination. There's so many places, and whatever you love and are passionate about, there's a way to do that as a nurse.
That is a great answer. And can you, just for people who might not know what a maternal mortality review board is, can you just give a few sentences about what that's like and what it does?
Yeah, absolutely. So many jurisdictions, often at the state level, but sometimes at the city level, are charged by local governments to conduct reviews of any person who dies during pregnancy or within 1 year of pregnancy. Now, there are other kinds of mortality reviews like infant, violence, homicide. I work with maternal mortality reviews. So we are charged through the Office of the Chief Medical Examiner and appointed by the mayor's office. We receive cases that are extracted by professional extractors who look at the health history, but who also look at interactions with child protective services, with the police, with other social services and housing, to give us a really comprehensive look at what their lived experience was. Then we're an interdisciplinary team of about 20 to 30 people, including physicians, doulas, midwives, nurses, community members, child advocates, and members of the Department of Health. We review the cases and look at what are the factors that contributed to this death. And then we make recommendations, and we direct those recommendations to government agencies. And at least within DC, those government agencies are obligated to respond to our recommendations and say, this is what we did, or this is how we're going to modify. It's one of the most meaningful actions I've done as a nurse and in my clinical career, to see some of the most catastrophic events generate positive recommendations and generate evidence that says we can do this better. And one of the most important findings from our last annual review of the MMRC is that we have to move care into the community. We have to care for people earlier in their lifespan, before they're developing chronic diseases in pregnancy. We have to take care of children exposed to adverse childhood experiences, to children in the foster care system, to families experiencing homelessness. Because yes, women are dying of cardiovascular disease and hemorrhage, but when you look at the lived history, there are all of these social determinants that are coming beforehand. And that's our public health responsibility.
Thank you. Craig, do you want to talk a little bit about the ways that nurses are kind of teamed up with housing and to affect health?
Yeah, I think the discussion has been so rich, and I think that the idea that you find nurses in so many different parts of life is so critical. And one place where I think there's a push to try to expand the role of nursing is in the role of federal housing programs. So in Vermont, there was this great model called STASH, which was about trying to support seniors in federally assisted housing to help them live more independently, to help them remain out of the hospital. And based on the success of this model, it was there's a pilot that's going on right now in across many different federally subsidized housing properties called the I-WISH model. And I think that this type of model where there's a nurse embedded in the properties where they're able to work to try to coordinate care, to try to do kind of wellness models of care is just like, it's so exciting because it presents these options to move upstream and to try to address some of the social determinants before they become kind of the problems that land people in the hospital.
Thank you.
Yeah, so if it's okay if I jump in there, I love hearing these conversations because we're actually doing, there's an initiative we have at our startup where we're doing a lot of user discovery about these non-traditional nursing roles. And in the interviews that we've done, we've actually learned that when we asked nurses like, well, how did you hear about these different roles? They said, well, it's usually word of mouth, like first and second degree connections and things like that. So I think a panel like this is a perfect way to just shed more light on these areas. I get a lot of students and alumni who reach out who even ask me like, how did you get into this? How did you transition into the tech world? And I'm sure people would wonder like, how do you transition into federal housing? Like where is my place in that? And more I just see the value of the perspective and the voice of the nurse. There's so many times where a nurse points out something from their experience that everyone else on the team had not considered, and that may completely change the way a program works, you know, at a federal level. It may completely change the interface that a platform uses or the way that something's operationalized for a technology. And I think it's hugely important to have nurses really kind of, I'm going to use the word infiltrate all these different areas of healthcare, but I think it's truly important, and we're learning that sometimes nurses don't know how to break into those fields. But I think having panels and conversations like this and bringing experts together is a great way to kind of get the word out and give nurses that confidence to know like you have a really valuable perspective to bring in all these areas to improve health outcomes. So, yeah.
Great. So thank you. And okay, yeah, lost my thought. Any predictions in the next 30 years where you see healthcare going and opportunities for the health of our nation and for nurses?
Well, I think we are going to redefine primary care. I think it's already begun, but I think primary care is going to become an approach, not necessarily a practice, an approach that is owned by everyone who's part of the healthcare team. And I also see us beginning to embrace a wider web and network of care providers, using community health workers, having RNs embedded at specific points in the community, and then using networks with institutions and healthcare systems to bring in the level of care that they need. But creating analog as well as digital and virtual on-demand care, and that's really where self-management is, is that they can demand what they need. Excuse me. And so I think with that redefinition of primary care as an approach, that's where we're really going to be able to move forward.
Thank you. Other thoughts?
Yeah. And I just want to add to that. I think I totally agree with what Catherine said. And I think, many of us know that the healthcare system now is very reactive. Like we're really good at providing sick care rather than healthcare. And something that we've been working on in our pilot at Pocket RN was this notion of a proactive visit. And I will say the first time we talked about that with nurses and patients, there was a little bit of confusion. Like, well, what does that mean? Because people are so used to accessing care when there's something wrong, when they need something. But after a few sessions, both patients and nurses realize the value of having a proactive visit where you are, you're not coming because there's an issue. And this is more than just your annual checkup. We're actually going to talk through what you're supposed to be doing on a daily basis to keep yourself healthy, right? What are the things that your doctor said at your last visit that you're supposed to be doing? How's that going? And start brainstorming ideas to help them really incorporate that into their everyday lives. And I will say we've gotten some feedback from patients, and they said that they're just not used to accessing care this way because they feel like the healthcare system is so busy. But now that they have access to it, they realize, oh, it's so great. I get this undivided attention of a nurse who has all this knowledge, and I can ask these questions in this very safe and non-threatening environment. Patients say that actually having those regular proactive visits that they know are coming up just keeps their health at the top of their mind when they have a lot of other competing priorities. And the nurses have said at first, they're like, I don't know what I'm going to talk about, because they're not used to being able to get this uninterrupted time to do some education and coaching. But once they had a few of them under their belt, they're like, this is amazing. I get to finally talk about these things that I barely have time to at discharge or barely have time to talk about in the clinic visits. And so we've been seeing that. And I really think that is the future, right? We need to really be thinking about how do we proactively take better care of our health for all of our population, rather than responding to a lot of these issues that are happening later down the line. So, yeah.
Yeah, I think that, oh.
Please go ahead.
I was going to say, I think that powerful reimagining of health care as something that happens in partnership, like what you were talking about, Marini, is so important, and that I hope that we'll see change. Right now, I'm working with Community of Hope to develop a transformed model of postpartum care. Like many of you know, right now, the standard of care for postpartum is 1 to 2 visits in the first 6 to 8 weeks, and then have sex, exercise, good luck with that baby. And there's all of this infant care, but really there are so many health changes. And part of our model for postpartum care, like what we, a group of nurses, a group of midwives, think it should look like, is someone going to the home in the first month, is group-based care in the 2 to 6 month period to build that social connection and confidence in parenting and changes to the body. And then a transition to primary care, like what you're talking about, this proactive visit in the 6 to 12 month period, where that birthing person can return their attention to themselves and say, am I eating? Am I sleeping? Is my blood pressure under control? Did I ever update that pap smear? Do I want to have more kids? When do I want to have them? How is my mental health? What's going on with depression and anxiety? And this idea that we as healthcare providers in a healthcare system are providing an open and receptive space to help someone proactively look at their health trajectory, either in this primary care setting or at these critical junctures of change. And pregnancy and birth is one of those like high intensity critical junctures that can really be a changing level set for an individual and their family. And the other thing related to this 30-year trajectory that I hope and fear is that we have a transition in our workforce, right? That our workforce continues to expand, but also that we receive the compensation, the remuneration, the respect, and the work environments that our training, our expertise, and our care really deserve. Because globally, the nursing healthcare workforce deserves more. We are doing the brunt of primary care, of caring for people in their homes globally. Midwives are delivering most of the babies. And yet compared to how the healthcare system works, we're often undercompensated. We often come with mission-driven commitment to our work that sometimes is taken advantage of. And I hope over the next 30 years, the professionalization, the compensation, and our work environments continue to be and grow into even better places to thrive professionally and personally, so that we have the level of health and wellness that we hope for our patients.
Wonderful. Well said. So as we wrap up, I'd love to go around and to have people, any final takeaway, any final thing you think of, anything you want the audience to know, or any thing you particularly connected with about what somebody else said. So, let's see. If anyone wants to jump in, or I can call on people, but kind of as we wrap up, a takeaway or something you want to leave the audience with. Katie, do you want to?
Sure, yeah. So, I think this was such a wonderful panel, and I loved listening to everybody's responses to questions. I think the one thing that really stands out to me as we talk about kind of the future of healthcare and the future of primary care, which I loved your response there, Dr. Ling, I really completely agree. I think for this intersection between access to care and technology for the future is really going to be where things are headed. And I think, meeting people where they are, whether that means at faith-based organizations, at schools, out in the community, or through some form of technology. And the one thing that I did want to just touch on, we've started using a two-way text platform. It's a HIPAA compliant text platform. And we've started small. We've been piloting it with at-home COVID tests. And so we're distributing thousands of at-home COVID tests to our population. They don't know how to use them. They don't feel confident in the results. And so we have community health workers who are texting back and forth with them. They're snapping a photo of their results, sending it back, saying, is this a positive or a negative? When do I use this? All of these kinds of questions, they have this person kind of at their disposal. They can text back and forth whenever is convenient for them. So those kinds of platforms and things like Pocket RN and all of these things that can help provide services to people where they are, I think is only going to improve the health of the population as we go forward. And I'm excited to see where it goes.
Nice, thanks. Who would like to go next?
Maybe I can go next and just pick on something that, again, Catherine was talking about around the networks of providers and kind of moving towards a focus on health that Mirni was talking about. And I think that with that, I want to try to expand the team. And my hope is that in 30 years, that when we're thinking about healthcare, we're not just thinking about nurses and physicians and hospitals and clinics, but we're also thinking about people that are working on food security and housing security and transportation security and these broader range of issues, so that when we think about our safety net, we actually have a net rather than these individual streams that are so hard for people to weave together themselves.
Great. I was trying to figure out how to work in the health impact pyramid and getting down farther to that for more impact, but I was thinking it was too visual a metaphor for this, but thank you for bringing us there. Mirni or Catherine or Christina?
Well, this kind of panel gives me a lot of hope, because the things that we are projecting and talking about and seeing down the road that we're trying to bring in today's classroom, hearing them be actualized out in the community. And it's nice to see the future taking place right now.
Nice.
Yeah, I always, I wanted to wrap up thinking about, the students that I teach and work with who are coming into nursing or coming into a role as a women's health nurse practitioner or nurse midwife. And the first thing I ask them when they start is, why did you come here? Why do you want to do this? And the stories of the passion and these critical moments in their own health histories that are often the motivating factor for why you want to come into healthcare, why you want to be a nurse, why you want to be with people in their most vulnerable, most heartbreaking, and most joyous moments are so powerful. And I ask our students to write them down, because it's hard, right? And it's heavy work, and we love it. And so learning how to hold the two things simultaneously of how incredibly joyful and privileged it is to be part of people's lives, and how challenging and heartbreaking it can be, that learning how to hold those simultaneously is a professional skill that will build your resilience and longevity and commitment and passion in your career. And nurses are everywhere. Don't be afraid to make a shift, right? Go from clinical care to advocacy, to consulting, to technical advising, back to clinical care, to management, to oversight, to teaching. This can be a beautiful path.
And I'll let Marnie have the last word, but on that note, our previous dean, Trish Davidson, used to say, it's not leaving nursing when you do something else with your training. You never say that about a lawyer. You never say, she's not a lawyer anymore, she started a company, or she's not a lawyer anymore, she ran for Congress and she left the legal profession. But in nursing, people tend to say that, and I think with physicians too. And so, make a startup or go do something else and come back and do it all, and you'll always be a nurse with that assessment and those people skills and that understanding of context and advocacy. But Mary, anything you want to add in terms of a wrap up?
Yeah, no, I agree with everyone says. And I think just as Christina was saying earlier, nurses are in a tough place right now and often undervalued and underappreciated. And, I think just like they're naturally inclined to give a lot to what they're passionate about and to their patients, but everyone has their limits. And we're kind of at this point where we're really testing the limits of the nursing workforce. And I do think broadening kind of their perspective of all the options of where they can still be a nurse and still provide that value is so important, because the last thing we do want is for someone to just completely leave healthcare, and just walk away. Maybe it's that pivot into another area that extends that longevity of nursing. That's a phrase that we use a lot at our startup, is that what can we do to extend the longevity of nursing? And from our perspective, the telehealth aspect is one way of doing that, whether it's nurses who are transitioning into retirement, who are on family leave or medical leave, or other different options where maybe that traditional 3/12s is just not, feasible for this life stage for them. But I think, I love that we're having these conversations and we brought this group here, because it does give me hope for the future, just to see all the ways that we're really elevating the field of nursing and being able to make impactful change in healthcare. And I think nurses are really the ones who are positioned to do it and do it well. So yeah, it's been a really great discussion.
Well, wonderful. Thank you to everyone on the panel. Thank you for everyone who is listening. Thank you to everyone who will listen to it, not live. And we really appreciate it. Have a wonderful rest of the Nurses Week and the spring. And we will see you all soon.
Happy Nurses Week.
Happy Nurses Week.